Santa, hey 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 Santa. When are you going to Atlanta? Can I hitch a ride with you, old man? 'Cause my gal lives in Dixieland.
Hi guys! It's been a while since I've posted anything to the site, but I'm happy to have this up for all of you before we get into the holiday season. This month, I wanted to talk about 8 papers in the critical care arena that have made a change in my practice. There are 4 topics that I wanted to cover today. I wanted to look at the changing role of crystalloid fluids in resuscitation of the septic patient, and discuss the potential harms of hyperoxia in the critically ill patient. We'll review the potential uses for high-flow nasal cannulae in hypoxic patients, and last of all, consider the role of delayed sequence intubation in the patient with the difficult airway or the patient who you can't preoxygenate.
Well, Santa, don't bring me any toys, just bring my baby and a bottle of joy. That's right.
So since we're getting into the holiday season, I thought it would be fun to be a little politically incorrect and enjoy some pretty epic redneck Christmas decorations, starting with Santa taking a whiz. From all the trials that have been coming out on sepsis in the last couple of years, we know that giving fluids is one of the important things we need to do in order to improve survival in septic patients. But up until recently, no one had ever really looked at whether the composition of the crystalloids that we were giving really matters. There are basically 2 main flavors of IV fluid that we give in the ED, crystalloid and colloid. We all know the common crystalloids, normal saline, lactated ringers, and most of us have used a bicarb drip and some combination of D5 plus or minus this and that at some point. Plasmolite is a balanced solution that tends to get used a little bit more up in the OR and up in the unit. The colloid we tend to use the most in the ED is actually blood. We're not really using the hetastarches, and albumin isn't something we tend to give very much of either. Here is the big caveat I want to mention before we go any further. The following discussion is about medical patients. The super sick trauma patient doesn't get crystalloid, they get blood. So keep in mind that this whole discussion is about super sick medical patients, like the septic shock folks. So when we give fluid, we're basically trying to expand the plasma volume. Ultimately, we'd like our treatment to help get the patient back to something resembling normostasis, and so it helps to consider what the plasma is supposed to look like when we're thinking about what fluid to reach for. In reality, there are only really 2 crystalloid solutions that we typically use for resuscitation in the ED. Normal saline and lactated ringers are what we usually keep handy. I think most of us are still using normal saline for just about everything, but there is some recent data that ought to make us think a little bit before we just reach for the salt water. You'll notice that one of these fluids looks an awful lot more like plasma composition that we looked at on the last slide, and it ain't the saline. Lactated ringers is much closer to being a balanced solution than normal saline. Saline has about 30% more chloride than plasma does and has a lower pH, so you're going to start seeing a hyperchloremic acidosis occur as you begin infusing larger volumes of normal saline. There is some theory that this can result in an increase in systemic inflammation, decreased renal perfusion, and all sorts of other badness. It's because of this that some people actually refer to normal saline as abnormal saline. That being said, LR isn't perfect either. It's a little hypotonic, so it's probably not a great fluid to reach for in patients that have a brain injury due to the risk of increasing brain edema. But overall, it's probably a better choice for large volume fluid resuscitation. And just for funsies, here's the composition of plasmolite. We don't currently have this in our ED, but it's nice to know about the fancy pants fluids they're using up in the ICU and in the OR. Alright, now let's get into the good stuff. This paper is a propensity-matched cohort study of hospitalized patients who had SIRS and received IV crystalloids. The primary outcome was inpatient mortality, and they also looked at things like the length of stay, the readmission rates, and complications. They screened a whole lot of patients for this, over 90,000. 98% of the patients that they screened got normal saline as the primary resuscitation fluid, and only 2% got a balanced fluid. In this particular cohort, they were using plasma light as the balanced solution. And what they mean by a propensity-matched cohort is that they looked at the 1,700 and change patients who got the balanced solution and tried to match them as closely as possible to a similar patient in the saline cohort so that you could look at a selection of well-matched patients. So here's what they found. The one that I really want to point out is the very top line, which is the overall inpatient mortality. There was a 2% absolute difference in mortality that achieved statistical significance. Length of stay, readmission rates, dysrhythmias, coagulopathy, blah, blah, blah were also statistically significant. But I think that what we really care about in the ED is whether or not the fluid we're giving up front during the initial resuscitation matters for the patient's overall outcome. This paper suggests that it does matter. So here's another matched cohort study. This one selected out adult patients with severe sepsis, all of whom were in the ICU and required pressors. Their primary outcome was also inpatient mortality, with similar secondary outcomes as the prior study. They screened over 50,000 patients, 94% of whom got normal saline as the primary resuscitation fluid. They were able to come up with just over 3,300 matched patients in each cohort. Similarly to the prior study, they also found that there was a statistically significant absolute difference in inpatient mortality. What was interesting about this paper is that they also looked at the proportion of normal saline to balanced solution that the patients got and found that mortality followed a dose-response curve, such that the mortality was the lowest in the group that got the greatest proportion of balanced solution. Again, it mattered what fluid we started during the initial resuscitation. And because we all love a good meta-analysis, here's one that was published in the Annals of Internal Medicine last year that included almost 19,000 patients. Suffice it to say that they found the same result, that patients who were resuscitated with a balanced crystalloid had lower overall mortality than patients who got normal saline. So why is it that we're using saline? Probably because it's cheap, and there's also some of the "it's what we've always done" factor involved too. I wondered if it was more expensive to use balanced crystalloids, so I looked them up. Please note that this is the wholesale cost of these fluids taken from a medical supply website, and it might be a little bit different where you're actually practicing. And this is most decidedly not what the patient is charged. That being said, yes, plasma light is about 4 times more expensive than normal saline or LR, but for a patient who's sick enough to need large volume resuscitation, ICU admission, pressors, the 28 extra bucks you could spend to infuse 4 liters of a balanced solution is pretty much peanuts. And just to put things in perspective, a liter of Pepsi costs about the same as a liter of LR. Let's wrap up with the take-home points. Next time a supraseptic patient that needs fluid resuscitation rolls in, keep in mind that there's nothing normal about normal saline. It's a non-physiologic fluid and at large volumes will produce a hyperchloremic acidosis. But the big ticket take-home from these papers is that we can make an impact on the septic patient's overall mortality by using a balanced fluid when we're resuscitating them. It's probably just fine to use saline for the generally healthy patient who isn't really sick and who's just going to get a liter or 2 and go home. But if the patient might be septic or looks like they are going to need resuscitation, from now on I'll be reaching for the LR instead.
Don't wanna leave my comfy cozy, but the baby's lips are hot and rosy.
Because nothing says Christmas like a nice pile of reindeer guts.
Hot buttered rum. When you hear me holler now, you better come. 7,11, baby just died.
Let's switch gears and talk about something else we use pretty much indiscriminately in the ED: oxygen. During residency, I was taught some pretty basic tenets of physiology that generally apply to every patient. Number 1, air goes in and out. Number 2, blood goes round and round. Number 3, oxygen is good. But can you have too much of a good thing? There are papers that have looked at this recently, and it seems that maybe you can. It's theorized that maybe by giving patients supernormal levels of oxygen, we might be harming them more than we're helping them due to the formation of free radicals that can chew up at-risk tissue, potentially worsening end organ injury. How about STEMI patients? When you have an area of the heart that isn't getting perfused and is essentially starving for oxygen, it makes perfect sense to think that giving the patient extra oxygen to try and increase oxygen delivery to the injured tissue would be a good idea. And that's exactly what we've all been taught to do and have been doing for years. In this paper, which was a multi-center prospective RCT, they included 441 patients with a confirmed STEMI, and they were randomized to either get supplemental oxygen at 8 liters per minute versus no supplemental oxygen. Their primary outcome left a little bit to be desired, since infarct size based on enzymes isn't really a patient-centered outcome, but they had some important secondary outcomes that are worth considering. The differences in troponin levels here didn't reach statistical significance, and frankly, I don't really care that much about lab values because it doesn't tell me anything useful about the patient. That being said, there were some pretty big differences in the secondary outcomes that are hard to ignore, even if they were just secondary outcomes. The rates of recurrent MI, arrhythmia, and infarct size in grams as measured by cardiac MRI at 6 months were all statistically worse. It would be nice to know if mortality was affected, but they didn't specifically look at that. Either way, there really isn't any evidence that giving oxygen has ever done anything good for patients with STEMI, and now we have some evidence that suggests that we really don't need to be giving non-hypoxic patients supplemental oxygen when they're having a STEMI. Now let's talk a little bit about cardiac arrest patients. It seems like it would be a good idea to give a bunch of oxygen after a cardiac arrest as well. I don't honestly think you can hurt anyone with supplemental oxygen during the arrest. You can't make them any more dead than they are during a cardiac arrest, after all. But say you get return of spontaneous circulation. Now what should you do about oxygen in these folks? This paper from JAMA looked at that question, and it was a big multi-center cohort study of adults that suffered a medical arrest who were resuscitated and achieved ROSC. All of them were classified as being hyperoxemic, normoxemic, or hypoxemic based on their initial post-ROSC ABG. I liked the outcomes that they chose to look at too, because I think they're outcomes that we really care about, including mortality and favorable neurologic recovery. What they found in this paper actually kind of blew my mind. They found that hyperoxia was just as bad, if not worse than hypoxemia in regards to both survival and good neurologic recovery. They did a pretty good job trying to control for as many potential confounders as possible, and despite that, hyperoxia was still bad. Again, I don't think you can really do any harm by giving oxygen while the patient is still in arrest, but if you do get ROSC, titrate them down quickly to maintain O2 sats around 94 to 95%-ish and get them off the high FiO2 quickly. So based on this, yes, you can have too much of a good thing. Hyperoxia worsened mortality in the post-cardiac arrest patient that achieved ROSC, and it's probably not doing anything good in the STEMI patient either. There is one major caveat that I want to add to this whole discussion, and that is that none of this discussion applies to the preoxygenation phase preceding intubation. Hypoxia is bad too, so if you're planning to do RSI, please preoxygenate your patient just like you normally would. And then, after you tube the patient, go ahead and titrate that FiO2 back down to physiologic levels quickly.
Make that a double. Come on now. All right. Woo.
Not really sure, but I think it's supposed to be some kind of a redneck sleigh. Or something. High-flow nasal cannulas are kind of the in thing in emergency medicine and critical care right now. But with such high flow, are you going to just blow your patient away? We'll keep this one pretty short. High-flow nasal cannulas are pretty cool. They can produce a huge amount of flow, and you can titrate them to a pretty precise FiO2. And they heat and humidify the oxygen, so patients can tolerate it pretty well. In this paper, they did an open-label trial of patients that had hypoxemic respiratory failure. They didn't include patients with hypercapnia, since a nasal cannula isn't really going to fix a problem with ventilation. They were randomized to high-flow therapy, standard O2 therapy through a face mask, and to non-invasive positive pressure ventilation, i.e. BiPAP or CPAP. What they wanted to know was whether this therapy could potentially help you prevent a patient from being intubated. What they found in this trial was pretty interesting. There was a non-significant trend toward a decreased need for intubation, but they weren't able to show a statistically significant benefit. That being said, their sample was relatively small, so it's not clear if they would have achieved statistical significance if they had a larger sample. However, their secondary outcomes were interesting as well. They showed a decrease in mortality that was significant for patients getting high-flow nasal cannula therapy, as well as more vent-free days. Ultimately, we need more data to make any real conclusions, but this does seem to be a promising therapy that we're probably going to start seeing more of. The take-home point from this one is that high-flow nasal cannula may be coming to an ED near you. So far, the data looks pretty promising, and there's a lot of interest in this modality right now, so expect to see some more coming out of this in the literature pretty soon. For now, it's a good adjunct in patients with hypoxemia, although there is some data that the flow being generated by the device may provide a small amount of PEEP. It's probably not going to rescue the patient in flash pulmonary edema or who is in respiratory failure with a PCO2 of 100 that needs a lot of PEEP.
Come on, Santa! Let's go!
This one is just total genius. What a great idea for a non-traditional Christmas decoration, and what a great way to freak out your neighbors.
See my baby! Hey, can I hitch a ride with you, old man? One more time.
Of course, no discussion of critical care in the ED is complete without at least one paper about the airway. Emergency medicine as a specialty is really in part defined by our critical resuscitation skills and in particular our ability to manage the airway with expertise. We're accustomed to using RSI, to pre-oxygenating, and to using a wide variety of adjunct devices to secure the airway. We're also familiar with the process of procedural sedation and maintenance of the airway during that process. But what do you do when you're faced with a patient that you can't pre-oxygenate? Dr. Scott Weingart out of New York has done a lot to move the specialty forward in regards to ED critical care, and one of the major advancements that he has pioneered is the concept of delayed sequence intubation, in which pre-oxygenation itself is the procedure that you're trying to facilitate. When all of us trained, we learned that the goal of pre-oxygenation is to achieve nitrogen washout of the lungs by replacing it with oxygen. In essence, we're creating a reservoir of oxygen within the lungs that can prolong safe apnea time. All of us just sitting around probably have a good couple of minutes of oxygen in our lungs, and we can extend that time with effective pre-oxygenation. However, in patients that are super sick, they're likely to have a higher overall oxygen consumption in their hypermetabolic state, and are likely to have much shorter safe apnea time. Patients that are super sick are also more likely to have problems with oxygenation due to physiologic shunting. So let's take a second to talk about that. A physiologic shunt is caused by areas of alveoli that are blocked from conducting oxygen but still have intact blood vessels surrounding them. The obstruction usually happens because the alveoli are filled with fluid like pus or blood or something else that creates a barrier to gas exchange. This perfusion without any ventilation leads to direct mixing of deoxygenated venous blood into the arterial system, and typically is the problem when you have a patient that you can't oxygenate with your normal techniques. Consider the normal lung, in which oxygen enters the alveoli and raises the saturation from the venous level of 70% to nearly 100% by the time it reaches the arterial side. In shunt physiology, no oxygen is actually getting into the alveoli, so the venous saturation is never increased. In the shock state, cellular oxygen extraction is also much greater, such that the venous SVO2 can be markedly lower than 70%, like it would be in the normal physiologic state. In such low SVO2 situations, the alveoli also can't raise the low venous saturation to the normal arterial level. When you have both of these problems present, the arterial desaturation becomes even worse. Most of us remember learning about this curve in medical school, and this is really the reason why we're shooting for O2 sats of about 90% or higher. When the O2 sat is above 90%, the slope of the curve is shallow, and desaturation occurs slowly. However, once you hit about 88 to 90%, the slope of the curve starts to become much steeper, so desaturation will start to occur much faster once the patient goes over that edge of the cliff. So what can we do to optimize our pre-oxygenation? I like this rule of 15s because it's just an easy way to remember these 4 steps that will help you maximize your preoxygenation. The addition of a nasal cannula at 15 liters underneath the non-rebreather or the ambu mask allows nitrogen washout in the upper airway via passive oxygenation and helps bring the FiO2 up closer to 90% from just the regular 65% face mask. If you add the addition of some PEEP to the preoxygenation process, you can also recruit some alveoli and reduce physiologic shunting. And you can do that either by putting the patient on non-invasive ventilation or by using a PEEP valve on the ambu bag. Keeping the head of the bed elevated also prevents the contents of the abdominal cavity from pressing up on the chest cavity and may help decrease aspiration risk as well. If you're treating a patient who is morbidly obese, think about actually tilting the whole bed up about 15 degrees because that helps gravity just keep that big pannus down and prevents it from putting pressure on the chest cavity, and that reduces the restrictive component of trying to oxygenate those patients. If the patient about to be intubated is in shock, the patient will probably tolerate the physiologic challenge of intubation better if you can ensure that the patient has adequate preload, afterload, and inotropy. If you have time, give some fluids to fill up the tank and start pressors or get some push-dose pressors handy if the patient has refractory hypotension. And if the heart has bad squeeze, consider adding on an inotrope. If you can improve and maintain cardiac output, this is going to help your patient maintain oxygenation. Likewise, you'll also want to select an induction agent that will help support the patient's hemodynamics. In a patient who's hypoperfusing, ketamine is probably the ideal agent for this. Etomidate is probably also a reasonable choice, and a single dose probably isn't going to cause any clinically meaningful adrenal suppression, but for most of these patients, I'll still be reaching for the ketamine. All of us are so well trained with RSI that it's probably in your lizard brain and has probably become essentially a brainstem reflex at this point. We're really good at it, and the majority of the time, it goes great. But what do you do with that occasional super sick patient that you just can't get the sats up because they're delirious and you can't get them preoxygenated? All of us have seen that patient, and usually we just try to bag them up as high as we can and pray that the tube goes in easy. These are the folks where you may want to consider a switch to DSI as opposed to RSI. Think of DSI as 2 separate procedures. Procedure number 1 is actually a procedural sedation during which the procedure you're going to accomplish is preoxygenation. It might sound a little crazy, but it's actually a fantastic idea. Ketamine dissociates the patient, but they keep right on breathing, and it also preserves their airway reflexes. But it also takes the cray-cray out of the equation, and your delirious or altered patient will now allow you to do things like put them on a BiPAP mask that they wouldn't allow before. So here's the basic process. Once you've identified that this patient is going to be tough to preoxygenate, plan on a 2-step process to get that patient safely intubated. Step 1 is to identify the patient correctly and get all of your supplies together and make sure that your team knows the plan. Step 2 is to give the patient a full dissociative dose of ketamine, usually 1 to 2 milligrams per kilogram slow IV push. Remember that if you slam it in, you may have a brief period of apnea, but if you just give it slow IV push, the patient will just keep right on breathing. Step 3 happens once the patient dissociates. You can put your nasal cannula on at 15 liters, and you can add either a non-rebreather mask at 15 liters, or even better, put them on something that will give them some PEEP so that you can start recruiting some of those alveoli that are being shunted. If you have a ventilator in the room, you can use that and just attach a non-invasive mask to it and let the patient breathe with some PEEP for about 3 minutes, and their SATs should start to come up with these maneuvers. Step 4 sort of resumes where the RSI pathway left off. You've already dissociated the patient, so you just need to give the paralytic and then proceed with putting the tube in. Most of us are already using passive O's when we're doing our RSI, and since you've already got the nasal cannula on the patient in step 3, just leave it there and continue to passively oxygenate during your laryngoscopy and tube placement. What most of us really want to know is, does DSI really work? So here is the first and so far the only real paper on the subject. They enrolled 62 patients in the ED and the ICU settings, and these patients were selected for enrollment because they had delirium preventing them from proceeding with normal RSI preoxygenation strategies. Patients received a dissociative dose of ketamine, allowing preoxygenation with a high-flow non-rebreather mask or non-invasive positive pressure ventilation. After preoxygenation, patients were then paralyzed and intubated. The primary outcome is the O2 sat they were able to achieve after DSI versus their O2 sat just prior to initiating the DSI process. Of the 62 patients enrolled, after dissociation, 19 were successfully oxygenated with a non-rebreather mask, while 39 were given non-invasive positive pressure ventilation. 4 required an NG tube to be placed for decompression in order to be oxygenated. On average, the patients had an increase of about 9% in their pre-DSI saturations after the procedure. Here's a chart view of what happened to all of the patients in this trial. All but 2 of them improved their O2 sats, and most of them improved their O2 sats dramatically. The 2 that didn't improve basically didn't have any significant change and were never below 93% to begin with. A couple also had marginal improvement and couldn't be oxygenated all the way up to 93%, but it's notable that none of the patients that started out hypoxemic got worse. All of them improved, and I'm comfortable saying that this technique looks like it's safe and is probably better than what we've been doing. The most critical take-home from this paper for me was that they identified 32 patients as being high risk for critical desaturation before they started the DSI procedure. All of them had SATs below 93% when they started, and all of those patients increased their O2 SATs by undergoing DSI. In fact, the majority of them were able to achieve an O2 SAT greater than 93%. And while the sample is too small to make any major conclusions, none of the patients in this series got worse as a result of DSI. Let's wrap up our last take-home points for the day. DSI works, and it's a great approach to that super sick patient that you need to intubate, but is either delirious, altered, or there's something going on that's preventing you from being able to adequately oxygenate that patient. Think of it as 2 procedures, where the first procedure is a procedural sedation such that the procedure you're trying to accomplish is the preoxygenation of the patient, and the second procedure is the intubation itself. And I'm going to go ahead and throw out a shameless plug for Dr. Scott Weingart's excellent MCRIT blog and podcast, which I highly recommend. There's great stuff there, and if you want to learn more about DSI from the guy that pioneered the concept, here's the web address, and I'll try to get a link to it posted up on this month's blog page. As always, thanks for listening, and happy holidays.
Can I hitch a ride with you, old man? 'Cause I gotta see my baby. Hey, can I hitch a ride with you, old man? One more time. Can I hitch a ride with you, old man?